Welcome to the Society of Critical Care Medicine's ICU Liberation Webcast, Roadmap for Implementing the New ABCDEF Bundle in Your ICU. My name is Lori Harmon, and I will serve as moderator for this webcast. I'm the Director of Quality at the Society of Critical Care Medicine, and I have no relevant disclosures. This webcast is funded by the Society of Critical Care Medicine's Council to encourage implementation of the 2013 Clinical Practice Guideline for the management of pain, agitation, and delirium in adult patients in the intensive care unit. In fact, we welcome a lead author on that guideline, Dr. Juliana Barr, as a speaker in today's program. We are invited to ask questions for our presenters throughout the webcast. You may do so by typing your questions into the question box in your GoToWebinar panel. Questions will be addressed after the presentation. This webcast will include approximately 40 minutes of content. Due to the short nature of this educational activity, there will not be CE or CME offered. You will also have the opportunity to participate in interactive polls. When you see the poll, simply click the bubble next to your choice. This webcast will be available at www.iculiberation.org or on FCCM's YouTube channel the next business day. We invite you to share this and the many other ICU Liberation webcasts and patient stories with your colleagues widely. Post on Facebook if you like this webcast, and if you tweet on during the webcast to spread the word. It is now my pleasure to introduce our speakers today. Our first distinguished presenter is Dr. Juliana Barr. Dr. Barr served as co-chair in the revision and publication of the 2013 PAD guidelines. Dr. Barr serves as a staff anesthesiologist and intensivist in the VA healthcare system in Palo, Alto, California. She has provided leadership and support for the Society of Critical Care Medicine's ICU Liberation Task Force and continues to champion methods to reduce long-term consequences for ICU patients and their families. Dr. Barr will serve as faculty for the West Coast Gordon and Betty Moore Foundation ABCDEF Bundle Improvement Collaborative starting this fall in 2015. Secondly, we will learn from an accomplished nurse and leader in quality improvement, Ms. Ann Barnes-Daly. Ann is a regional clinical initiative lead at Sutter Health System in Sacramento, California. Two of Ann's focuses at Sutter Health are in the areas of hospital-wide sepsis improvement and pertaining to today's program, implementation of the ABCDEF bundle in the critical care setting. Ann is currently serving as a national expert faculty for the FCCM and Gordon and Betty Moore Foundation ICU Liberation Campaign Collaborative and is a valued member of the Society of Critical Care Medicine's ICU Liberation Task Force. Now it is my great pleasure to hand over today's program to Dr. Barr.
Thank you, Lori. I'd also like to thank the Society of Critical Care Medicine and the Gordon and Betty Moore Foundation for making this webcast possible today. Today I'll be speaking about the ICU Liberation Campaign's ABCDEF bundle. As Lori mentioned, I was the lead author of what are commonly referred to as the ICU PAD guidelines and also a member of the ICU Liberation Task Force and financial disclosures today. By the end of this webcast, you should have a clear understanding of what the elements of the new ABCDEF bundle are and how to implement them in your ICUs. But we'd like to start this webcast off with a poll of the audience. How often are you integrating the ICU PAD guideline recommendations into your clinical practice? Please answer and choose one: never, sometimes, most of the time, all of the time, or I don't know. Like a little over a third of you are using the PAD guideline recommendations most of the time, and about a third some of the time. and less than 10% are using them all of the time. So it looks like the majority of people on this call today stand to benefit from what you're going to hear in my presentation and Ann Barnes-Daly. So let's go on. In 2013, the Society of Critical Care Medicine published an updated version of their sedation and analgesia guidelines entitled The Clinical Practice Guidelines for the Management of Pain, Agitation, and Delirium in Adult Patients in the Intensive Care Unit, also known as the PAD Guidelines. These guidelines take a more integrated, interdisciplinary, and holistic approach to the diagnosis and management of pain, agitation, and delirium in critically ill adults, linking PAD management to other evidence-based practices. The PAD guidelines strongly advocate for using valid and reliable assessment tools to assess pain, agitation, and depth of sedation and delirium in all ICU patients, optimizing pain management first before initiating or increasing sedation, avoiding deep sedation, and preventing and treating delirium, emphasizing non-pharmacologic strategies over medications. They also link PAD management with ventilator weaning protocols and early mobility efforts in order to achieve additional synergistic improvements in ICU patient outcomes. This approach enables ICU patients to actively participate in their care, promote their recovery, and to reduce harm to patients. The PAD guideline recommendations were incorporated into a single ICU PAD Care Bundle, which was originally published as part of the PAD guidelines. The ICU PAD Care Bundle provides a roadmap for developing integrated, evidence-based, and patient-centered protocols for the assessment, treatment, and prevention of pain, agitation, and delirium in ICU patients. More recently, the Society of Critical Care Medicine, in partnership with the Gordon and Betty Moore Foundation, have launched the ICU Liberation Campaign to promote rapid and widespread adoption of the PAD guideline recommendations. Similar to the Surviving Sepsis campaign, the ICU Liberation Campaign aims to improve the care of critically ill and injured patients using an integrated, interprofessional, team-based, and bundled approach to the assessment, treatment, and prevention of pain, agitation, deep sedation, and delirium in patients. In 2010, Dr. Pratik Pandharapande and colleagues at Vanderbilt University first coined the phrase ABCDE Bundle to promote evidence-based best practices for managing delirium in ICU patients. This bundle included coordinating spontaneous awakening and breathing trials to facilitate weaning from mechanical ventilation, sedation and analgesia strategies that minimize the risk of ICU delirium, using valid and reliable delirium assessment tools to monitor patients for delirium, and promoting early mobility and exercise in patients to prevent ICU delirium and ICU-acquired weakness. The ICU Liberation Campaign has taken a similar mnemonic approach to facilitate adoption and adherence to the PAD guideline recommendations by developing the ABCDEF Bundle checklist. This mnemonic reminds ICU providers to routinely assess and manage pain in all ICU patients, perform daily spontaneous awakening trials and spontaneous breathing trials in ventilated patients, pay attention to the choice of sedation, routinely monitor and manage delirium, perform early mobility and exercise patients, and engage and empower ICU family members in these care processes. The overarching goals of the ABCDEF bundle are to help optimize pain management, break the cycle of deep sedation and prolonged mechanical ventilation, reduce the incidence and duration of delirium in ICU patients, improve both short and long-term ICU patient outcomes, and ultimately to reduce healthcare costs. Many of you have previous experience in implementing the ABCDE bundle in your ICUs, and you may be asking yourself at this point, Well, beyond the addition of the letter F, how do these two bundles really differ, and haven't we already been there, done that in our unit? The ABCDE bundle was created prior to the ICU PAD guidelines and focused only on preventing ICU delirium and ICU acquired weaknesses. The ABCDE bundle includes only RASS scales for sedation monitoring and CAM for delirium monitoring, and does not recommend specific treatment strategies for managing pain, sedation, or delirium. And it doesn't include ICU family involvement. By contrast, the ABCDEF bundle is based on the PAD guideline recommendations and takes a more comprehensive and integrated approach to assessing, treating, and preventing pain, agitation, or deep sedation and delirium in all ICU patients. The ABCDEF bundle recommends specific assessment tools for monitoring pain, sedation, and delirium, and provides more explicit definitions of significant pain, agitation, deep sedation, and delirium based on these assessments. The ABCDEF bundle also includes both pharmacologic and non-pharmacologic treatment and prevention strategies in each of these domains. And finally, it includes ICU family engagement and empowerment in the care of patients. But why use a bundle? A bundle is a limited set of evidence-based practices that, when performed collectively and reliably, have been shown to improve patient outcomes. Individual bundle elements are well-established best practices, but when these practices are applied individually, they're often not applied uniformly, making treatment unreliable and idiosyncratic. A bundle ties these elements together, prompting clinicians to collectively apply the same set of interventions to every patient every time. Bundles can also improve ICU team communication, standardize care processes, and reduce practice variability. In general, bundles can achieve greater improvements in patient outcomes than if each evidence-based intervention were applied to patients separately. Examples of other highly effective ICU bundles include the sepsis bundle and bundles to prevent device-related infections, such as ventilator-associated pneumonia, catheter-related bloodstream infections, and catheter-associated urinary tract infections. By bundling pain, sedation, and delirium management together with other evidence-based practices like spontaneous awakening trials, spontaneous breathing trials, and early mobility protocols, greater synergistic benefits can potentially be achieved than if these interventions were applied separately. But what's the evidence for this? Previous studies published prior to the PAD guidelines showed additional improvements in ICU patient outcomes when pain, sedation, and delirium management were combined with either spontaneous awakening trials, spontaneous breathing trials, or early mobility efforts. More recently, Michelle Ballas and colleagues were to demonstrate the safety and efficacy of implementing the ABCDE bundle to prevent delirium and ICU-acquired weakness in patients. They conducted a single-center before and after study, including 296 mechanically and non-mechanically ventilated ICU patients admitted to 7 ICUs and step-down units at a large tertiary academic medical center over a 2-year period. Their bundled approach linked the coordination of SATs with SBTs and early mobility efforts with a delirium monitoring and management program. Measured outcomes included ventilator-free days, the prevalence and duration of delirium and coma, the frequency of getting ICU patients out of bed, ICU and hospital mortality, length of stay, and disposition following hospital discharge. Patients in the pre- and post-bundle implementation groups were similar, except that patients in the pre-implementation group were slightly older. Following implementation of the ABCDE bundle, ventilator-free days increased by 3 days. The odds of developing delirium decreased by 45%, and the odds of patients getting out of bed increased twofold. There were no observed differences in complication rates, length of stay, mortality, or discharge disposition between the two groups. Although the frequency of SATs and SBTs performed did increase following bundle implementation, there was no significant difference in sedative or opioid use or the incidence of deep sedation between the two groups. These observed improvements in ICU patient outcomes were achieved despite little difference in medication exposure between the pre- and post-implementation groups of patients, and despite incomplete bundle adherence. Christopher Dale and colleagues have also shown significant benefits to bundling ICU PAD management with SATs and SBTs. They conducted an observational before and after cohort study of over 1,400 mechanically ventilated ICU patients admitted to their 24-bed trauma surgical intensive care unit over a 2-year period. They implemented an integrated ICU PAD management protocol that included routine PAD assessments that were linked to an analgesia sedation protocol that optimized pain management first and preferentially targeted light sedation and a multimodal delirium management protocol. This integrated PAD management protocol was also linked to daily SATs and SBTs as a single intervention bundle. Measured outcomes included the frequency of patient assessments with the RAS and CAM ICU instruments, benzodiazepine use, delirium incidence, duration of mechanical ventilation, ICU and hospital mortality and length of stay, and associated pneumonia rates. Adjusting for differences between the pre- and post-bundle implementation groups, in this study, ICU patients were more likely to receive routine PAD assessments. Benzodiazepine use decreased by more than a third. Mean RAS scores significantly increased, meaning patients were less sedated. Patients' risk of developing delirium decreased by 33%. Duration of mechanical ventilation decreased by nearly 20%. ICU length of stay decreased by over 12%, and hospital length of stay decreased by 14%. There were no observed improvements in VAP rates, mortality rates, or discharge status in these patients. It's important to note that none of these previous studies incorporate all elements of the ABCDEF bundle as a single intervention, and all of these studies have been single-center trials and not multi-center trials. Full implementation of the ABCDEF bundle is expected to have an even greater positive impact on ICU patient outcomes and healthcare costs. But the real question is whether these results can be replicated across a wide variety of ICU models. Each hospital and healthcare system will need to implement the ABCDEF bundle in a way that fits best with their ICU and hospital culture. There is no one-size-fits-all approach here, but there are some common, effective implementation strategies that can be used to ensure successful implementation of the bundle. In the second half of this webcast today, you will hear from Ann Barnes-Daly of Sutter Health, Sacramento, who will share her experiences with implementing the ABCDEF bundle and its impacts on ICU patient care across 7 hospitals in a single healthcare system. And now for our second poll. Which of the clinical elements of the ABCDEF bundle are you routinely using in your ICU, and choose all that apply? The use of a pain management protocol that includes routine pain assessments, coordination of spontaneous awakening and breathing trials in mechanically ventilated patients, use of a sedation protocol that includes routine sedation assessments and treatment strategies tailored to the sedation needs of each patient, use of a delirium management protocol that includes routine delirium assessments and utilizes both pharmacologic and non-pharmacologic delirium treatment and prevention strategies, and finally, the use of an ICU early mobility protocol. Again, choose all that apply in your ICU. Management protocol, and you're also, you have a sedation protocol. A little over half have a delirium protocol, and the majority of you are already linking your protocols with SATs and SBTs, and a little less than half have early mobility and exercise. So that's actually terrific. What I can see here is that a lot of you have the individual elements, but maybe you haven't implemented 100% of the bundle elements yet in your unit, but you're well on your way. So that's terrific. There's no question that the implementation of the ABCDEF bundle will require a significant amount of time, effort, and institutional resources with necessary investments by all stakeholders involved in the care of ICU patients. But the potential payoffs are great in terms of its impacts on ICU patient outcomes, hospital efficiencies, and healthcare costs. How much money would your hospital save if it could reduce ICU length of stay by 2 to 4 days? How many more patients could you care for in your ICU by opening up more beds? How many more of your patients would survive both their ICU and hospital stay and return to a higher quality of life after discharge? The Society of Critical Care Medicine, the ICU Liberation Campaign Task Force, and the Gordon and Betty Moore Foundation are committed to making these outcomes a reality for our patients through the ICU Liberation Campaign. We anticipate that the campaign will be fully deployed over the next 2 years and will eventually become sustainable, similar to the Surviving Sepsis campaign. There are a number of ways that you can connect with the campaign through the ICU Liberation website, which has valuable new content being added all the time. By participating in future FCCM webcasts and podcasts that will take a deeper dive on implementing individual elements of the ABCDEF bundle. By attending the upcoming ICU Liberation Campaign Conference in Nashville, Tennessee in September 2015, which will be co-sponsored by Vanderbilt University and the FCCM. By participating in the ICU Liberation Campaign National Collaborative in the United States, which has a fast approaching application deadline of May 19, 2015. Later this year, the FCCM will be publishing a new book entitled ICU Liberation, The Power of Pain Control, Minimal Sedation, and Early Mobility, which will be available online for purchase. There will also be the launch of the ICU Liberation REDCap database, which will allow hospitals to benchmark their performance in implementing the ABCDEF bundle and its effects on ICU patient outcomes. And finally, the next version of the ICU PAD guidelines is scheduled for publication in 2017. So stay tuned. And with that, it is my true pleasure to introduce Ann Barnes-Daly of Sutter Health Sacramento, who will be sharing her team's experiences implementing the ABCDEF bundle in 7 ICUs across their healthcare system. Ann?
Thank you, Dr. Barr, and thank you for that excellent review of the PAD guidelines, the ABCDEF bundle, and the revisions and improvements that have recently been added, and the use of bundles in general and why they're important. I do not have any industry affiliations. I am working with Society of Critical Care Medicine and the Gordon and Betty Moore Foundation on the following task forces, both for ICU Liberation and for the Surviving Sepsis campaign. When we talk about ICU Liberation, we're talking about liberation from many things that occur to patients in the ICU as a result of what we would consider routine care. I know that some of you are familiar with the term ventilator liberation. When our group looked at the type of liberation we wanted to provide for our patients, it was additionally liberation from deep sedation, from the bed, and the outcomes from immobility. Also liberating patients from delirium, from post-traumatic stress disorder that many patients experience after a stay in our ICU, and ultimately from death. What I want to talk to you about today is taking these amazing guidelines, the tenets of the ABCDEF bundle, and provide you with some practical information on how to actually implement them for your patients at the bedside. To reiterate, Sam, I'm having a little trouble with control of the slides. Can you go back? I'd like to go back to the slide that has the bundle on it. Thank you. To reiterate, here are the elements of the ABCDEF bundle that Dr. Barr expertly described to us. When folks look at the bundle, one of the things I hear from hospitals who really are interested in implementing the bundle is they want to move right to early mobility and exercise. It is one of the most exciting aspects to the bundle, and folks are really interested in liberating their patients from the bedside, from their beds. But what we have to realize is that assessment of pain is better managed when a patient is awake. Providing spontaneous awakening and breathing trials, choice of analgesia and sedation, delirium assessments, and engaging the patient as well as their family really begins with the overall reduction of sedation that can occur from head injury or cerebrovascular accidents. But in our case, what we have control over is the amount of sedative medication that we provide to patients as a routine part of their ICU stay, specifically for patients who are mechanically ventilated. One of the things that's really tantamount in the PAD guidelines is something called the pain first approach, where we first medicate a patient with analgesics related to their pain assessment, and then at that time we assess the patient for their level of sedation and only add additional sedative medication if the patient is not within their sedation target, which outlined in the PAD guidelines in the ABCDEF bundle, although not explicitly, is the least amount of sedation where the patient can be both calm but awake, alert, and take part in their care. Okay, when we look at implementation from a systems perspective, and that system is your ICU, and we look at the individual bundle elements, it's true that there are primary accountabilities for each of these disciplines for each of the ABCDEF domains. So for instance, for awakening and analgesia, it is the RN who's primarily responsible for awakening the patient for their SAT, for providing assessment for levels of sedation and level of pain, and for administering those medications as directed. However, there is additional team member responsibility to the provider, the physician, for ordering the types of sedation and analgesic medications that will be administered, and typically, and in our project, a pharmacist or PharmD who weighs in on the choice of medications that are most applicable and appropriate for the individual patient. For breathing trials, specifically the respiratory care practitioner would administer those, but in concert with an awake patient, which happens during the spontaneous awakening trial, and appropriate medications and settings on the ventilator that are provided typically from the physician, and again, pharmacy input to make sure that the patient is optimized to be able to comply with the breathing trial to give them the best opportunity to be extubated as soon as possible. Coordinating the awakening trial and breathing trial and choice of medication, again, are administered by the RN and respiratory care practitioner, but in concert with the physician and the pharmacist. In our project, delirium assessment was really undertaken by different disciplines depending on their role with the patient. Also, prevention and mitigation is an important role for the entire team. Exercise and early mobility, although may be assessed and started by the physical therapy or rehab personnel, often becomes the primary responsibility of the RN, and for intubated patients, it's required that the respiratory care practitioner partner with mobilizing the ventilated patient to make sure that their respiratory and ventilatory needs are met while their activity is increased. Engaging the patient and family in rounds, for instance, or at least in the plan of care is important because no one knows the patient better than themselves or their family members. It is important to include them, not just to explain the ABCDE bundle and how they can participate and support that work with their loved one, but also how they can help us to understand the care goals and the needs of the patient who's in the bed so that we can work together to create the best possible experience and outcomes for our patients. We call the ABCDE Bundle a team-administered protocol. The assessments, the SATs, the SBTs, the CAM-ICU, the Richmond Agitation Sedation Scale for a level of sedation, and functional mobility assessments, for instance, are all administered by different members of the team. The treatments, mobilization, reducing ventilator settings, moving towards extubation, and those types really are most effective when implemented by nursing, respiratory care, physicians, pharmacists, and physical therapy and rehab staff working together as a coordinated team. One of the things that I hear is challenging for hospitals that are actually implementing the bundle is the frustration of disciplines who perform assessments on patients and report those assessments perhaps in rounds or to other care providers, only to have them fall on deaf ears. It's important then, when nursing is trained and implementing assessments such as pain assessments, particularly for nonverbal patients, assessments around level of sedation, and around delirium, it's important that those are shared, not just shared with, but acted on by other members of the care team. What we've found success with is discussing these parameters and assessments in rounds and collaborating to update the care plan to meet the needs of the patients. One thing to examine is, what do your rounds look like? Are there specific scripts in your rounds that speak to each element of the ABCDEF bundle? Do you use your assessments and collaborative decision-making around next steps to modify the plan of care, always including the patient and family? And are your rounds multidisciplinary versus interprofessional? We'll talk about those differences in just a minute. This cartoon depicts 3 different models of teams that work together in the ICU. On the top left, you'll see what's termed the traditional model, and this employs expert decision-making. For instance, this is the ICU where the physician comes to see the patient, assesses various parameters, looks at tests that have been ordered, and decides the treatment for the patient. That person would write orders which would be carried out by the nurse, respiratory care, physical therapy, and pharmacy, and those orders would reach the patient ultimately. That's the expert decision-making model. In a multidisciplinary model, a model in which many of you likely practice right now, there's more of a consultative decision-making, and what that means is nurses, pharmacists, respiratory care practitioners, and physical therapists, each experts in their own domain, provide information to a central decision maker, typically the physician, who takes in all this information under advisement and then writes orders which are meant to be carried out and ultimately reach the patient. This is differentiated from the interprofessional care model. You'll see the pictorial here showing that instead of a decision maker being at the center, the care or patient's care plan is at the center, and each member of the group shares equal footing, each an expert in their own domain, including the family and patient being experts in themselves or their loved ones. Information is provided to all members of the team around assessments and, most importantly, recommendations for next steps and revision of the care plan. For instance, a respiratory care practitioner may say, I performed a spontaneous breathing trial in concert with an awakening trial provided by the patient's nurse. The patient passed the spontaneous breathing trial's safety screen and passed the breathing trial itself. I recommend that we extubate this patient as soon as rounds are over. At that point, it is up to the decision of the team in a collaborative decision-making model to concur with the respiratory care practitioner. And if an order needs to be written, it can be done so by either the physician or the PharmD. I wanted to specifically focus on the new letter in our bundle, the F, and to ask how well you engage and empower the family in your unit. Please choose the answer to the following question. How well do you engage and empower the family? and choose all that apply. Do you invite families to participate in bedside rounds? Do you hold rounds off the unit so the family is not able to participate? Do you schedule regular family conferences? Or do you meet with family members only as needed when a problem arises? Do you include your families so that they can routinely participate in developing plan of care? I see by the results here that over half of you actively invite families to participate in bedside rounds. I'm happy to see that less than 10% hold rounds off unit, although I know that is a practice in many hospitals and even some of my own affiliates. Family conferences are a really good way to keep families informed and also to include them in decisions around creating a plan of care. I see about half of you meet with families only as required. And this is a challenge because family members really need to feel included, both in decision making, but also many family members want to know what they can do to help their loved one get better. Interprofessional team development is not natural. In our work in the 7 affiliates at the Sutter Health in my region at the time of our project, we spend equal focus on both the teaching and integration of the clinical aspects of the ABCDEF bundle, as well as 12 two-hour sessions with interprofessional teams identified at each affiliate to learn, understand, implement these key aspects to a functional interprofessional team. We coordinated together to do the IT, which is how do we utilize plan, do, study, act cycles at the patient's bedside to implement each one of the ABCDEF elements? How do we use SBAR to communicate between disciplines to share important information about assessments and patient condition? How do we work together to plan the patient's care, and how do we sustain the change, not just among ourselves, but also with other members of our discipline? How do we cooperate by developing self-awareness about how we come across to our colleagues? How do we optimize communication? How do we use contrasting statements like, what I don't want is for the patient to sustain bad outcomes because we're over-sedating them. What I do want is for us to work together to meet sedation targets that will best serve our patients. And how do we provide feedback to folks who are maybe not with the program and providing evidence-based care that we've worked so hard to implement in our unit? How do we create a partnership with the patient and family? How do we create a sense of team in our ICU rounds? And how do we share and collaborate on decision-making so that every person feels that their input, their suggestions are valued, considered, and contained in the patient's plan of care? So how we knew that we were successful and how you can gauge your own success is by implementing an interprofessional team platform and continuing to improve on that collaboration as you move your project forward. This allows for more efficient resource use with less energy, including time, money, supplies, and/or goodwill between different disciplines working together in your ICU. It's important to demonstrate sustained compliance with assessments and interventions of the bundle. I believe that you will see reduction of ICU mechanical ventilation days and reduction of your inpatient mortality. Our ultimate goal, however, and our definition of success is that we have reduced long-term physical and cognitive harm to our ICU survivors. It's no longer sufficient to improve our mortality outcomes when the patients who are leaving our ICUs, although alive, cannot return to their lives as they were before their stay with us. Our project in the Sacramento Sierra region of Sutter Health included 7 ICUs in 7 different affiliates in the Sacramento Sierra region. We identified 4 cornerstones for success in our project. Of course, it was important that we implemented evidence-based practice, and the pain, agitation, and delirium guidelines were the main platform that we used. We knew we wanted to create interprofessional teams at each affiliate, but we also wanted to reduce the silo effect that had happened in our hospitals before by creating a collaboration across the entire region of all 7 hospitals so that everything was standardized and that patients were receiving the same level of care at each of our 7 affiliates, although they are different sizes of community hospitals. And ultimately, we wanted to reduce the practice variation that really was resulting in adverse outcomes for our patients. The way we made those 4 cornerstones functional was we selected an RN lead in each of our ICUs. This was not a program that was added to the ever-expanding platform of our educators and CNSs. This was an RN that we took from staffing who was either a formal or informal lead in their unit to focus on this project and nothing but this project for 12 months. We were able to do that through, in part from a generous grant from the Gordon and Betty Moore Foundation. However, I think that you can also use this strategy in your ICU. Most of you probably have very experienced and well-recognized RNs in your unit that can serve in this role. We created teams of subject matter experts in each discipline, one from respiratory care, physical therapy, nursing, physician, and pharmacy, who really acted as mentors and teachers to other members of their discipline. As mentioned, we provided interprofessional team training. We created data collection so that we could track and provide information about the quality improvement project and to show that we really were making strides. And we inserted ICU rounds. Some of our hospitals didn't even have rounds in the ICU, and those who did have ICU rounds, we made sure to insert a script around the IPT model and the ABCDEF bundle. We used the IHI model for improvement, the Plan, Do, Study Act, or Plan, Do, Check Act, as we implemented each bundle element one at a time to make sure there was understanding about how each of those integrated with desired patient care. We use the tenets of the 4 E's, which is engage, educate, execute, and evaluate. Being experienced with other quality improvement projects at the regional and system level, we realized that just providing folks with the PAD guidelines or the science behind the ABCDEF bundle was not going to be sufficient. We took a step back, and our first effort was to engage the hearts and minds of the people who we wanted to recruit to work on this project with us. We presented them data on patient outcomes. We showed them videos of patient stories, heart-wrenching sagas of how patients survived their ICU stay only to be left with physical, cognitive, and psychological sequelae to their stay, to the point where some of them really wondered whether they were happy they survived or not. Starting with that as a platform brought people to the table to understand that the way we were doing things was no longer acceptable. And although we thought in the past we were doing the best for our patients, we needed them to understand that we have new data that shows us that there are new ways to do things that not only keep our patients alive when they leave the ICU, but can return them to their lives. For education, we educated them both on the clinical aspects of the ABCDE bundle and the PAD guidelines, but also on the tenets of the interprofessional team model, and had them practice that each week. For execution, we had them integrate each of the tenets of the bundle into their daily practice and to address and update the care plan within IPT rounds at the bedside in the ICU. We also created a data collection tool and a platform for reporting their progress so they could see how well they were doing implementing this quality improvement project. One of the things I hear many people say is, this is going to take a huge culture change in my ICU. And I really asked our original teams to remove that culture change jargon from their vocabulary and to back up and start small. When we talk about the whole bundle being enabled by decreasing sedation levels, I asked them to begin with learning the Richmond Agitation and Sedation Scale, assessing patients routinely using that scale, and to modify their sedation practices to reach a sedation target of a RASS of 0 to -1, which means the patient is awake and alert, but relaxed and not anxious. We started with that one behavioral change, which then enabled other parts of the bundle to be accomplished. Once the patient was more responsive, we were able to assess them for delirium. We were able to more easily and efficiently perform a spontaneous breathing trial, and of course the ultimate goal of liberating the patient from the bed and allowing them to mobilize was much more efficient, obviously, when the patient was awake, alert, and able to participate in their care. So I asked to remove that entire huge, often overwhelming concept of changing the entire culture to changing the behaviors of our practitioners one at a time, which cumulatively allowed us to have a great deal of success implementing the bundle. These bar graphs show the results that we had across our 7 ICUs in 2014 in implementing each of the bundle elements and in all or none bundle compliance. Some of the baselines you'll see are relatively high because we weren't even doing some of these elements, so our baseline is really taken from just the first quarter. But what you can see is both the awakening trial, breathing trial, as well as the coordination of those with the RN and respiratory care practitioner, choices of sedation, delirium monitoring, and early mobility and exercise have all reached or exceeded our goal for all of our patients, being 80%. And at the end of 2014, we had an all or none bundle compliance of just shy of 90%, which I think is excellent results for this process. So interestingly, we have this great bundle compliance data, but the question is, how does this affect our outcomes? How does this really translate to what's best for our patients? This is a pre-publication graph of our results analyzed for all of our patients who were included in the bundle over our 7 ICUs for the calendar year of 2014. There are over 6,000 patients included in this data set, which encompasses over 14,000 patient days. And what this data shows us is that the higher compliance that we have providing the bundle to patients in an all or none fashion, the greater chance the patient has of surviving their ICU stay. So hospital survival increases 24% for every 10% that we increase our bundle compliance. So patients that had little or no bundle compliance have mortality rates just above 60%. And this is for all comers, intubated, non-mechanically ventilated patients, sick and less sick, that when we have a 100% all or none bundle compliance, our ICU survival rate is close to 93%. We recently received these data, and we were ecstatic to see on paper what we knew in our hearts to be true, that our efforts to implement and sustain the ABCDEF practices have dramatically improved the mortality outcome for our patients. But in addition, they've improved the level of functioning for our patients when they leave the ICU. Our project was not without challenges. We really took the PAD guidelines and the evidence behind the ABCDE elements as our gold standard. It was difficult to shift practices that were based on outdated evidence or no evidence whatsoever. Another challenge is that we took one team from each ICU and took them through the training for the interprofessional team model. And we would have hoped, looking back, that we could have brought more folks through that training. Mentoring your peers and leading by example is a really strong tool. Although providing that kind of platform and influencing your peers sometimes is more difficult. We did take the rest of our clinical staff through education around the bundle elements, but trying to influence them in rounds every day can be challenging. And the last challenge, of course, is collecting data so that you can track and show your performance and use real-time data to give feedback to practitioners to improve care on a day-to-day basis. Look at your performance and respond to opportunities to improve care for your patients at the bedside. I'll leave you with this quote: "You never change things by fighting the existing reality. To change something, build a new model that makes the existing model obsolete."
Thank you very much, Marianne, for that compelling presentation, and that data, I'm sure, is going to stick with everyone on this webcast today. It was very important for you to share that, so thank you. And Dr. Barr, certainly for your presentation as well. We do have a few questions we'd like to share with our faculty. Our first question is that the physicians in this particular hospital don't feel that the bundle needs to be ordered on patients who are in chronic ventilator status, perhaps ventilating at home or on chronic status in other locations. And what are your thoughts on that? Dr. Barr, I'll let you answer first.
So if I'm interpreting the question correctly, it sounds like the definition of a chronically mechanically ventilated patient is somebody who either came into the ICU from home or a SNF on a ventilator, or who leaves the ICU on a ventilator. And I think that regardless, we really don't differentiate between patients who have been on the ventilator chronically or acutely when applying this bundle. So it should be applied to all patients all the time. Obviously, if somebody's vent dependent and they were bedbound before they came to the ICU, you're not going to get them off the vent and have them walk again during their ICU stay. But for patients for whom that's a new condition, the goal should be to try to get them over their acute illness or injury and minimize their sedation, maximize their pain control, and aggressively prevent and treat delirium in those patients so that you can get them out of the ICU sooner than later, alive.
Thank you for that. Marianne, I'll let you take this one. What strategies can institutions with limited manpower use to effectively roll out an ABCDEF bundle?
Yeah, I think that's a great point. You know, we had a community hospital setting, but we did have the great fortune of having a grant to do this work. But I'll tell you, I'm rolling it out to the rest of our 21 affiliates starting at this point. We don't have those same type of resources. So I think you know, what we're looking at is providing the same amount of information, but maybe doing it in kind of smaller doses. What I would say is start. What that means is start with just implementing one thing. So if you have an educator or a CNS or even a lead nurse or a manager who's enthusiastic about this program, start with teaching the assessment tools around sedation. Work with your physicians to order evidence-based targets for sedation, that is a RASS of 0 or -1, so patients can be awake, and practice reducing sedation levels and working with patients who are more awake. Then move on step by step to each of the other bundle elements. If it takes you a year to get all of these in place, you will have served that many more patients over the 12 months. So I would start small with a small group of enthusiastic folks, create them, help them to become subject matter experts, have them be mentors and model the way for their other peers until you have one bundle element pretty much reliably and validly implemented for your patients, and then move on to the next one.
Very good. Thank you. Dr. Barr, do you recommend a certain period of time between stopping sedation and performing the CAM-ICU assessment? And if not, will you not be overdiagnosing hypoactive delirium?
When you stop somebody's sedation, their emergence time is unique to that patient. The pharmacokinetic and dynamic response to the sedatives, how long they've been on the sedatives, will determine the rate at which they wake up. But the threshold for performing delirium assessments is defined by their level of alertness, not whether or not you're concerned that they might have residual drug effect that's causing the delirium. I'm not sure if I'm answering that person's question as they intended, but
Julie, let me piggyback on that.
Yeah.
The CAM-ICU specifically designates sedation level. So, for instance, if a patient has a RASS of -4 or -5, you are meant to not perform the CAM-ICU. It's felt that the patient is not awake enough to respond appropriately. Right. So that would be the case. If the patient has a RASS of 0, -1, -2, or -3, then the CAM-ICU has been validated for assessment of delirium in those patients. So to concur with Dr. Barr, if the patient meets sedation assessment criteria, then they can move on to the delirium assessment, and you can feel confident that the tool will be valid for use in those patients.
Yes.
The next question is, how many patients per intensivist do you have in your unit model?
Marianne, do you want to take that?
Yeah, interesting question. So the hospitals that I worked with initially in our 7-hospital project, only 3 of them actually had intensivists at all. Some of them are managed by hospitalists, and even we have open ICUs where even some community physicians initially were working with patients. So we don't have a standard. I think what's great about our data and the project in general is that we have such varied practices. I had some hospitals that have 4 beds in their ICU, and 1 hospitalist in the entire hospital, and other hospitals that have 32 ICU beds with 24/7 intensivist coverage. So the point is that this bundle is applicable in all of those settings for every patient. And just to follow up on a question that was asked previously, most patients in your ICU do not meet criteria for every bundle element. And so, for instance, the patients who are not mechanically ventilated are not going to get an SAT or SVT. Patients who are chronic ventilator patients are probably not going to get a spontaneous breathing trial. But the goal is to apply every element to every patient for which they meet criteria. And so applying the bundle uniformly to all patients and then specifying for particular patients which bundle elements they are able to receive allows every patient to gain maximum benefit from having this protocol widely used in your unit.
Great, thank you. And we have more questions than we have time. I'm just going to read a couple more. I know we're at the top of the hour. One question asks, how applicable are your results to medical ICUs with mean ages of 70 to 80, so the aged population? Julie, do you want to take that one?
How applicable are the results or the bundle?
It says the results to medical ICUs.
So these recommendations apply equally to both medical and surgical ICU patients, regardless of admission diagnosis or age, as long as they're adults. There's a separate set of guidelines in progress for children, of course, but as it applies to adult patients, this applies equally to all across those diverse patient populations.
And my data specifically, although I don't have the demographics here on the slides, of course there's a wide range of patients, and some of our hospitals do in fact have a more aged population than others. And some studies show that being of advanced age makes a person more susceptible to developing delirium, and some are kind of equivocal. Again, I think the aspect is to give the patient the opportunity to have the benefit of the bundle, and they will have better outcomes than not having it. So whatever we can optimize for our patients, regardless of age, is really the goal of implementing the bundle unit-wide.
I see a number of questions related to staffing. So several people in the audience are concerned that perhaps the staffing levels, Dr. Barr and Marianne, in your units for physical therapy and nursing is higher, 1-on-1 or 1-to-2 in these kinds of ratios, and so therefore that might be why you were successful. Can you address that?
Yeah, in our units, we didn't change staffing at all. The nurse that we talked about who was leading the project did not take care of patients. He or she were really there to inspire, lead, mentor, teach, and collect data. We did add a 0.5 FTE physical therapist to our units that didn't have one assigned. That was just to provide a baseline for the understanding from our physical therapy department that the role of the physical therapist was important, not just for patient care, but also rounds. And every single hospital, as a result of that kind of pilot staffing of physical therapy, has now assigned a physical therapist to the ICU and have added a 0.5 FTE to their overall department. But nursing staffing does not really need to increase. Patients are more awake, and they do interact with staff more, but they're also interacting with their family more, and the family actually can help with interceding with some care and care requirements that the patient needs.
Another similar question, I suppose, that relates to staffing in some respects, but certainly in resource-poor settings. I presume this individual is perhaps outside the United States and wondering, or even maybe in an urban setting where the staffing isn't quite as good, whether or not physical therapy presence is necessary to be able to accomplish bedside exercise and mobilization. Julie, do you have a comment for that?
So I would refer people who are interested in learning more about early mobility to two resources. One is there is a current recording of a presentation given by Heidi Engel, a real leader in ICU physical therapy at UCSF, and she gave this at a recent FCCM Congress panel. And she will go through, I think, in elegant detail how to implement early mobility program in the ICU. But you need some definition that I think is beyond the scope of, I know is beyond the scope of simple range of motion and getting a patient to sit up in bed or sit in a chair in order to accelerate mobility appropriately. And the other resource is Dale Needham at Johns Hopkins has an ICU rehab group there, and I encourage people to take a look at that. But you at least need some input from physical therapists as subject matter experts when you're thinking about implementing an early mobility program, in my opinion, even if you don't have full-time physical therapy staffing in your ICU, at least to get started so that everyone's on the same page about what that looks like and how to achieve that safely and effectively and expeditiously. Marianne, did you want to comment on that?
Just to say that in most settings, the RNs do primarily take responsibility for mobilizing patients. And for intubated patients, that's along with the respiratory care practitioner. Physical therapy is there as part of the interprofessional team. And the physical therapists in our program actually created and authored the mobility protocol. So they were also part of the project as subject matter experts, but they're not required to be at the patient's bedside to affect mobility. Often they're the ones that encourage mobility and help get patients up and encourage nurses to move patients more than once a day. But their presence is not absolutely required. The goal is for patients to leave the bed under their own power. And however you can affect that with the best utilization of your resources should provide you with some level of success.
So since we're just a little over time, I'd like to conclude the webcast today by thanking Dr. Barr and Marianne for your efforts in preparing for this educational program and sharing your expertise with our audience. You can share this webcast with your colleagues by visiting iculiberation.org. As mentioned earlier, we will be putting this on FCCM's YouTube channel for viewing. We will have another webcast this month on May 28th, and the title for that is Successfully Overcoming Assessment and Treatment Challenges for ICU Pain. So please do register for that and join us. Thank you, everyone, for your participation today. Have a pleasant day.
Thank you, Lori.